Welcome back. Dr. Rockhold again. In the second of 3 sessions on anxiolytics and sedative hypnotics. In this session, we're going to cover in more detail the benzodiazepines, the barbiturates, and the Z drugs. While the session will introduce a variety of actions and indications for these 3 drug groups, it will focus particularly on their sedative hypnotic properties. As the cartoon suggests, there is a strong association of these drugs for the management of sleep disorders. But you should be aware that there are meaningful distinctions between natural sleep and the hypnotic effects produced by these agents. I think you already know that human sleep has a natural structure, and recognize now that sedative-induced hypnosis differs from that natural sleep structure. An example of an EEG recording from an individual in a sleep lab is shown in this particular slide. Normally, about 3/4 of normal sleep time is spent in non-REM sleep. Of that, about half is usually spent in relatively light stage 2 sleep. Sedative-induced hypnosis in general induces somnolence more rapidly than normal, and it increases stage 2 sleep time at the expense of the time spent in slow wave stages and in REM sleep. Associated with sedative hypnotic use is also a tendency for rebound insomnia to develop when the drugs are discontinued. Difficulties in walking, clumsiness, and falls are real possibility in many patients when under the influence or after awakening following taking these drugs. And then finally, you need to recognize that a number of compulsive behaviors, sleepwalking, sleep eating, sleep cleaning, and sleep shopping, have been known to occur in patients taking these medications, and these can be very troubling. Typically, under the influence of these drugs, a patient will act normally during the behaviors, but retains no memory of their actions at that time. We'll discuss barbiturates and Z drugs separately, but with this slide, I'd like to focus first on the indications for the use of the benzodiazepines. There are a number of pharmacokinetic differences among the benzodiazepines that we'll introduce later. These are significant, and they often determine the choice of drugs for different indications. For example, midazolam, or Versed, is available for IV use for rapid sedation, while somewhat longer-acting agents like diazepam or Valium and alprazolam or Xanax are more commonly used for anxiolytic actions. Please bear in mind increasingly that serotonin reuptake inhibitors and other non-sedative hypnotics are considered first-line agents for anxiologists. The choice of agents for managing sleep disorders depends somewhat on whether the patient has difficulty getting to sleep or staying asleep. The longer-acting agents will be used preferentially for individuals who have trouble in maintaining sleep, whereas the shorter acting drugs tend to be used preferentially in patients who have trouble just getting to sleep. The muscle relaxation actions of these agents are useful for treating muscle spasms and various types of seizures. I believe you will hear more about the anticonvulsant action of these drugs in the anticonvulsant lectures. Let me start by emphasizing that the cartoon on this slide is definitely meant to be tongue-in-cheek because benzodiazepines have very well recognized adverse effects relating to dependence, tolerance, withdrawal, and abuse liability. You need to first of all recognize that all of the benzodiazepines currently are controlled by the DEA, as Schedule IV agents. They carry a distinct abuse liability. Tolerance to the drugs and dependence on these drugs occurs commonly with prolonged dosing. Remember the lines from Mother's Little Helper. Physical withdrawal is characterized by excitatory somatic and central nervous responses. Many patients relate the severity of withdrawal to be intensely unpleasant and prolonged. And of particular concern is the fact that the withdrawal events, especially the seizures that can occur, may be life-threatening. The life-threatening potential of withdrawal from the benzodiazepines is in specific distinction from withdrawal from dependence on opiates, the latter of which, while very unpleasant, does not usually include seizures, nor is it considered to be life-threatening. So that important distinction between withdrawal from an opiate versus withdrawal from a benzodiazepine is worth remembering. I'm not going to delve into specifics, but you need to recognize going forward that you will have to understand the differences among hepatic biotransformation and metabolism among the benzodiazepines and the barbiturates, because these have important distinctions in the choice of agent and the use for which that agent is prescribed. Particularly for the benzodiazepines, the relative importance of hepatic phase 1 and phase 2 metabolism will differ strikingly among the different agents. Lorazepam, as one example, has a primary pathway first to phase 2 conjugation reactions and then through urinary excretion. Others, for example, diazepam, goes strongly first to a phase 1 reaction, only then is it further metabolized by phase 2. You also need to recognize that some of these agents will have metabolites that are pharmacologically active. And in some cases, the duration of action that's noted in a patient may be very different from the elimination half-life of the parent compound that was administered because of a longer acting metabolically active byproduct. And all of this discussion should alert you to the possibility of drug interactions with other agents that are metabolized by the same groups of hepatic enzymes. Here, I'd like to say a few more words specifically about the benzodiazepine antagonist flumazenil, or romazicon. Flumazenil is a benzodiazepine derivative. Again, it acts as a pure antagonist at the benzodiazepine 1 receptor site. And what that means is, if you remember the cartoon on the GABA-A chloride channel complex, it binds at or near that benzodiazepine binding site on the exterior portion of the complex. Importantly, because they bind to different sites in the transmembrane region of the complex, ethanol, barbiturates, and meprobamate are not antagonized by the action of flumazenil. While it is available and can be used, the use of flumazenil is rather limited. It has a fairly short duration of action, so that in a massive overdose situation with a benzodiazepine, it may have to be administered more than once during the recovery. And more importantly, it seems to have an antagonistic effect more so on the sedative actions of the benzodiazepines than on any respiratory depression that may be evident during that period of intoxication. Finally, like naloxone in opiate-dependent individuals who overdose on an opiate, if you give flumazenil to a patient who is in overdose and is dependent on benzodiazepines, you're going to evoke abrupt antagonist-induced withdrawal. Care must also be taken when dealing with concurrent benzodiazepine and tricyclic antidepressant intoxication. The tricyclics also interact with the GABA-A chloride channel complex, and flumazenil will precipitate convulsions and life-threatening arrhythmias if tricyclic antidepressants are present in the overdose situation. Here we'll say a few words about the barbiturates. These are venerable drugs, and while their use is much more limited than it has been in the past, they are still available. As noted on this slide, we group barbs by their duration of action. Ultra-short-acting agents like pentothal have been used for induction of anesthesia, although that effect has largely been supplanted by propofol. Pentothal was used in lethal injection cocktails, but as lethal injection has been reviewed, the production of pentothal has been halted by some of the drug companies, particularly in the United States, and it's no longer available for that purpose. Short-acting barbs, as typified by secobarbital, have been used for sleep disorders in the past. However, secobarbital is no longer even available in the U.S. and thus is not used for that purpose. Long-acting barbs, like phenobarbital, can be used to help manage certain seizures, but again, other drugs that are less toxic and have a lower abuse potential have largely supplanted the use of barbs for this purpose. Recognize that barbiturates have no role in pain control, they have no analgesic action, and again, that their actions are not blocked by the antagonist flumazenil. On a somewhat literary note, secobarbital was known as one of the drugs referred to as the dolls in, at the time, wildly popular novel and film by Jacqueline Suzanne. The last group of drugs we'll talk about in this category are the Z drugs, zaleplon, zolpidem, and isoxaplone. These are all agents that bind to the benzodiazepine 1 binding site on the GABA-A chloride channel complex, and their action can be antagonized by flumazenil. Despite that feature of binding, the Z drugs are not chemically related to the benzodiazepine structure directly. Their use is primarily in management of sleep disorders, with the shorter acting agents, Ambien and Sonata, being used to aid in sleep onset, and the longer acting isoxaplone used also for those who awake repeatedly after falling asleep. Note that the Z drugs have little or no effect on muscle relaxation, nor can they be used to treat convulsions. They're generally well tolerated, they are less toxic than the benzodiazepines, but they can contribute to respiratory depression in co-intoxication situations with more powerful CNS depressants. They do have a recognized abuse potential, and the DEA currently regulates these agents as Schedule IV controlled substances. Let me end this session by emphasizing that significant anxiolytic actions can be found in drug classes that are not classically considered as sedative-hypnotics. While drugs in the barbiturate and benzodiazepine branches of the sedative-hypnotic tree have classically been used as anxiolytic agents, the serotonin reuptake inhibitors, buspirone, and gabapentin are more frequently prescribed for anxiolysis at the present time. Recognize the structure of the GABA-A chloride channel complex and the binding sites on that protein complex, and understand that those are critical for the mediation of the actions of the classical sedative hypnotics. That concludes the second of 3 sessions on anxiolytics and sedative hypnotics. The third session will be available.